Benjamin Hibbert, who's going to talk about the role of TEER in cardiogenic shock.
All right. Thank you very much for the invitation. My name is Benjamin Hibbert. I'm an interventional cardiologist as well, so we're slowly taking over. And I'm going to be talking to you guys today about the role of TEER in cardiogenic shock. And I'm currently based out of Mayo Clinic in Rochester, Minnesota. So before we talk about the problem, we have to define how big of a problem it is. This is Dr. Thiel's paper, European Heart Journal, Cardiogenic Shock Guidelines. And you can see a lot of the interventions that we do for these patients are based on expert consensus because of a lack of randomized clinical trial data. And in this data set, they suggested that up to 7% of our patients might be presenting with concomitant mitral regurgitation. And they suggest a heart team assessment and an assessment for intervention on the mitral valve. However, in practice in real life, this isn't what happens. So in 2021, we published the DORI-ME trial, which was a randomized comparison of milrinone to dobutamine in patients with cardiogenic shock. And I always like to give a shout out to the fellows that we involve in the trial and do these studies with us. We were interested in looking at how common is significant valvular disease in patients with cardiogenic shock. So this is Simon Parlow. He just completed his cardiology training. He's doing his critical care training in Ottawa. And we looked at what was the prevalence and the impact of significant valvular disease in patients in cardiogenic shock. And we looked at the 189 patients that ended up having an echocardiogram. 3 of the patients died before they could get an echo. And surprisingly, valvular heart disease is common in an undifferentiated population of cardiogenic shock. So this is heart failure and MI cardiogenic shock. So 40% of the patients had at least one significant valvular disease. About 5% of the patients had significant aortic stenosis, 20% of the patients had 3+ or greater than MR, and 17% of the patients had significant tricuspid regurgitation. And if you look, having a significant valvular lesion increases your risk of dying by about 50%. Perhaps not surprisingly, to those of us that treat valvular heart disease, aortic stenosis had a very poor prognosis, so it increases your risk of dying by about 2.5-fold. But having mitral regurgitation, even if it's functional, increases your rate of dying by about 60%. So this is not a benign thing to have concomitantly with your cardiogenic shock. And if we go back and look at the shock registry, if you had MR in the shock registry, your mortality was about 60%. So this is a very poor prognosis. And so we can conclude based on that valvular heart disease is common in unrestricted populations of cardiogenic shock, that if you have left-sided disease, TEER didn't really modify risk, but if you have left-sided disease, so AS or mitral regurgitation, increases your risk of dying by about 2-fold. And so this raises the question, should we be treating valvular heart disease in patients with cardiogenic shock? Now, in the olden days, trying to convince a surgeon to take your patient with functional MR in cardiogenic shock to the OR would probably be met with a lot of resistance, but we have new therapies that are minimally invasive to treat these diseases very effectively. So in 2020, we had started doing TEER in these patients with cardiogenic shock and getting good results. And so we wanted to go out and see what other people were doing and get a registry going of patients. So this is Richard Jung. He's currently an internal medicine resident at the University of Ottawa. And Trevor Simard, he was my PhD student. He's currently on faculty at Mayo Clinic as well as a structural interventionist. And we reached out and we looked to our colleagues around the world to say, what are you doing with these patients with MR and cardiogenic shock? And so we were able to identify a cohort of 140 patients that were treated with TEER with cardiogenic shock. Average age was 70. 87% of the patients were SCAI C to E, a predominantly male population. And again, we had very high fidelity data on 141 patients. So what happened to these patients? Well, the first thing is the bar graphs on the right. If you look, all of the patients had 3+ or 4+ MR when they were treated. And very similar to what we see in a stable population, 90% of the time you can treat severe mitral regurgitation in the shock state and get a good technical result. So get these patients less than 2+ MR. Not surprisingly, people get very anxious about this. The ejection fraction's dropped after treatment. That's normal. Your ejection fraction is dependent on your stroke volume, and if you're throwing it all into your left atrium, and all of a sudden we take that away, your ejection fraction will look lower, but your effective forward stroke volume is actually higher. So what happened to these patients? Again, they have an expected mortality of 60%. The in-hospital mortality for patients who were treated was 15.6%, but still a rising 90-day mortality at 30%. So much better than we would expect for a patient population with mitral regurgitation. And we were actually asked during the review process to present data on patients that had MR and were not treated, and we actually elected not to do that because, one, the mortality was astronomically high, and these patients were just hopelessly confounded. So obviously the patients we selected to go ahead and treat were a better patient population. But what we can look at is we can look at the patients that we successfully treated and compare them to the patients we were technically unsuccessful in. And what we found was that MR reduction is strongly associated with improved outcomes. Now, there might be differences that exist between patients in whom MR reduction can be achieved and those who it can't, but that if you had device success, you are much less likely to die at 30 days, 90 days, much less likely to be hospitalized. So successful treatment portends better outcomes. So Trevor then took the TVT registry, and this is almost a carbon copy of the analysis we just did with much larger numbers. TVT tracks all of the procedures that are done in the United States, and this isn't uncommonly being done. So we were able to get about 3,800 cases in the United States of patients that were treated with TEER that were either in cardiogenic shock on MCS or inotrope dependent. And again, you can see very good technical results. 90% of patients were able to achieve a significant reduction in MR, and very good clinical outcomes. In-hospital mortality of 9.1%. And if we were not able to successfully reduce your MR, your risk of dying was 20% higher. So again, more observational data suggesting this is good. Well, there's also a paper out of Europe. So Dr. Haberman and Dr. Shuvi have been big proponents of treating MR and cardiogenic shock, and they built an international registry as well, looking at patients with 3+ MR. It's acute MI, so it's not all cardiogenic shock. Only about a third of the cohort were in cardiogenic shock at the time of treatment. And they compared conservative therapy, surgical therapy, and percutaneous therapy. And what they were able to show and publish in the European Heart Journal was that intervention is associated with improved survival compared to conservative therapy. And if you look at those patients that are treated percutaneously with TEER versus those treated with surgical MVR, the patients that are treated percutaneously did better. So again, suggesting MTEER might have a role in these patients in cardiogenic shock. So what can we conclude based on this observational data? Well, MitraClip therapy in selected patients is safe. So there's very few procedural complications. You can take a patient on ECMO, you can take a patient on an intra-aortic balloon pump on multiple pressors to a cath lab and treat them without any hemodynamic consequences. The observed mortality is lower than we would expect based on patients in registries who have MR and cardiogenic shock. And we know that if you can get a better technical result, these patients seem to be better. Now I'm going to pause because we keep talking about registries and randomized clinical trials, and I would suggest that we need randomized clinical trials, and I'll tell you why. So we have a paper that hopefully will be out in the next few months. It's 2.5 million patients with cardiogenic shock over 20 years. And the mortality, if you were treated in 2020, is exactly the same as the mortality today. So we're doing more and more for our patients, but our patients aren't doing any better. And I don't want to come back to Houston Shock 2044 and say the mortality for cardiogenic shock is still 35 to 40% in our patient populations. And so, I wrote papers on transferring patients for cath and ROSC. I wrote papers on, intensive glucose control. And those randomized control trials in our critical care populations ended up showing that those observational trials, those registry trials that we did, ended up telling us to do the wrong thing. And so I think we need randomized trials so that we can lower mortality for our patients long term. And that's exactly what we're doing. So we're running the MINOS trial. So this is going to be 144 patients that are in SCI-D or C cardiogenic shock, in whom we can't wean the inotropes of the ventilator support. And we're going to randomize them to MitraClip or standard of care. We're going to exclude patients who've had out-of-hospital cardiac arrests. They can't have revascularization in the preceding 48 hours. If they have degenerate MR and they're a surgical candidate, well, surgery is still kind of the gold standard, so we'll do that. And then the primary outcome is either death or cardiac death. So in-hospital all-cause mortality, transplant, implantation of a durable VAD, or discharge on palliative inotropes. Thank you very much for your attention. I'd be happy to take some questions.
Esther.
So I think the key word is selected patients. So, but can you give us a little more detail on who you select for this?
Yeah, so obviously patients have to be anatomically suitable for TEER. Now that being said, thankfully most patients are anatomically suitable for TEER, but that usually is the first selection criteria. We like our patients to be hemodynamically stable. This is not the type of thing that you can take a patient who's got progressive shock to the cath lab. And then of course it has to be in a setting where the resources are available. So I just moved from Canada. I was in Ottawa, and I've moved to Mayo Clinic. So I went from a system where the resources weren't really available to do this easily. I'm not the Mayo Clinic. I can do a MitraClip at 7 o'clock at night if I want to. And so certainly, you need the right patient with the right anatomic considerations and the right resourced region to provide these services.
But did I I see an exclusion criteria 48 hours after revascularization?
Yeah, and that's just because a lot of these patients have functional mitral regurgitation. And so if a patient has undergone PCI to the RCA and they have ischemic MR, we feel that if you continue to support this patient, that secondary MR might resolve on its own if you do nothing to these patients. And so we want the patients to be revascularized, give them a chance for the revascularization to work. If they've got functional mitral regurgitation, that might just resolve because you've reperfused the RCA. And so we want to give those patients a chance to recover, because that might be a population that will get better if we do nothing.
Sure, that's the functional MR, but what if there is a caudal rupture or a papillary muscle rupture? You're going to exclude them?
Yeah, so we're excluding those patients right now if they've been revascularized.
But I think that is the group which will benefit the most.
If you've got a flail mitral valve because you've ruptured a PAP, we're really pushing those patients to go to the operating room or open label clip. So we just don't feel that there would be equipoise in those patients. And so when we were presenting this to our IRBs, people felt that the standard of care of therapy is surgery. I'm not sure if that's true. And people felt that these patients should be excluded in treating open label. If the patient is got a flail leaflet, they're 48 hours after they've been turned down for surgery, we'll randomize those patients. In the past, we let those patients die. And so we would not treat those patients. So we will randomize those patients in the centers that are randomizing.
But that equipoise should have come, because if you take the shock trial, which was very controlled with all the surgeons, only 8% had ischemic mitral regurgitation. Only 46% were even taken for surgery, which had 80% mortality. So we have that data. So why there's not a clinical equipoise? I know surgery in this situation is a very high risk, which has been proven with data. And you compare it with the technology, which is much less invasive than surgery.
Yeah, like I said, when we developed this protocol, people felt that those patients should be undergoing surgery. Just like degenerative, I think if you have degenerative MR and you're in cardiogenic shock, I don't feel that surgery is the gold standard, but people felt very strongly that surgical intervention is the gold standard for degenerative MR, independent of the patient's clinical state.
Dr. Hibbert, we have a question.
Of course.
Hey, Dr. Hibbert. Sukhdeep Basra from University of Texas here. So great talk, lots of data that you presented. Obviously, we're looking for some randomized data, and hopefully the MENOS trial will answer some of that. My own experience, at least from the MitraClip perspective, I can say it's all about patient selection. And I think based on what we see on COAPT and what we see in MITRA-FR, very discrepant results. Obviously, patients in shock were excluded from those studies. So in terms of patient selection, when somebody comes in SCI-D or E-heart failure, and you have an enlarged ventricle and you have severe MR and it's FMR etiology, but that patient's in shock, how are you, in your current understanding of this, stratifying these patients towards advanced therapies versus doing MitraClip for cardiac shock?
That's a great question. So I just finished a week of ICU at Mayo, and we had 6 patients in cardiogenic shock with severe mitral regurgitation. I can tell you every single patient was a debate with our advanced heart failure service about whether we should proceed with CLIP or whether we should just proceed with advanced therapies. So there is the MitraBridge registry, right? So that's an open label study that looked at patients that were awaiting advanced therapy. About 100 patients underwent MitraClip. At the end of that, only 25% still had an indication for advanced therapy. So I'm very much of the opinion this is an incredibly safe procedure. So when I take patients to the cath lab, I quote them a less than 2% risk of complications. There's very few things that I do that are this safe. 90% of the time I'm going to be able, in anatomically selected patients, I'm going to be able to get their mitral regurgitation to less than mild. And I don't think they lose anything by trying. So my clinical practice, and of course it's always a team decision, and when we're sitting with a patient in the intensive care unit who has an option for an LVAD or a transplant, the heart failure service is part of that discussion. My impression is, if those therapies are not immediately on the table and we're not immediately going for them, we lose very little other than resources in trying to do a MitraClip, stabilize the patient, and see how they respond to the therapy. And we've had very good efficacy. Not everyone believes that. And I'm hoping that if we're able to get randomized data, we're going to have a more compelling argument to say, this is part of the treatment algorithm for these inotrope-dependent patients, even these end-stage heart failure patients, to get them into a better place so they're a better candidate for LVAD therapy or transplant in the future.
I mean, I think this discussion comes up all the time in our team as well, and I always struggle with this. And I think sometimes it's pretty clear based on candidacy for advanced therapy. Some patients are good candidates, some are just not, so you have no option, then you go with this. But I think this may be a right time to maybe consider doing, or at least pitching it out there for the panel, to have a randomized trial in patients who are candidates for both advanced therapies and obviously an out-of-label CLIP. I think that would be the future, because we see this question, all of us struggle with this all the time. It's going to be a hard trial, but it'll really answer some good questions.
Yeah, I mean, I didn't talk about the long-term outcome data, but in the TVT data, we had up to 1 year follow-up, and we had 1 year follow-up in the JACC intervention paper. And the event rates are still very high at 1 year. So these patients, under no circumstance am I suggesting we clip their mitral regurgitation and, they're out running a marathon 3 months later. But going for advanced therapies when you're in cardiogenic shock and you have organ systems that are down isn't a great situation either. And so I really do believe this is free stroke volume, right? I mean, so many of the therapies that we're trying to implement are to augment stroke volume and cardiac output. The big problem is they have risks and complications with them. This is a relatively safe therapy that gets you a modest amount of stroke volume and is efficacious in most patients. So, my perception is let's clip them today. Let's move the ball downfield. Let's get them back on their GDMT, get them to be an outpatient when they can come in for an elective VAD, when they can come in for an elective transplant, as opposed to when their renal function's really poor, they're on pressors, and now we're going to an operating room in a decompensated state. And so I don't think by any means this is a replacement therapy for those more durable interventions. I think this is get you out of the fire, get you into a better place so that we can reevaluate your candidacy for some of these advanced therapies.
Thank you, Dr. Hibbert. We are running short on time.